Okay, good evening, everyone. I am going to, the title of my talk is regarding obstetric ultrasound updates and case-based refresher. I was supposed to give this in March. However, due to our pandemic, this was delayed until now. So it's going to be, it was intended to be a little bit more of a quiz format, but I did modify it. So it's going to be more of a lecture format tonight. So we will, first slide, I don't have any disclosures pertinent to this talk. So to kind of review the objectives of this talk, unfortunately, when I was a resident, I didn't really learn obstetric ultrasound, but when I entered practice, I was expected to know it. And, I felt like I was kind of hodgepodging a lot of information together over the years as I learned through experience. However, I was finally able to attend a conference last year in Seattle, which was an excellent conference. It was given by the a very esteemed obstetric radiologists from around the country. And it was a really good conference, and they focused mostly on obstetric ultrasound, lesser on gynecologic ultrasound. And in particular, the emphasis was on level 1 type of second trimester ultrasound. So tonight, I'm going to review some of those tidbits and pearls that I learned from that conference. And I have, since attending that, have incorporated some of those pearls and updates into our imaging protocols at Silver Cross. So I also wanted to go over some of the changes that were made to our OB protocols and why these were important. So there's many topics to cover. I'm not going to spend a lot of time talking about level 1 ultrasound. I'm just going to basically give you a few tidbits that I learned about what we need to talk about in first trimester ultrasound. It's just going to be literally one slide, but the majority and the rest of the talk is going to be focusing on second trimester. And basically we're going to be looking at fetal biometrics. How do we measure it? What's correct about that? What can go wrong? And then we'll move on to looking at these specific fetal survey structures. We'll look at soft markers. And basically my goal by the end of this talk for you is that to review a lot of situations that we come up with when we're reading these surveys. And basically I want you to know, when do you need to send a patient for a level 2 ultrasound? That's going to be the goal of this talk. So first trimester, just a couple tidbits. I mean, there weren't too many modifications that were made to our imaging protocols. Just to kind of remember the fetal dating, crown rump length is more accurate than measuring the mean gestational sac diameter. I'm going to admit Faraz here. And then a couple other things in terms of multiple pregnancies, like twin or triplets, we have to be mentioning the fetal number, of course, as well as the amnionicity and the chorionicity, and that's going to be documented and should be documented by our sonographers. So that should be part of the protocol. And then lastly, the other thing that they want us to also include, and this is also part of the ACOG and ISUOG criteria, is that uterine masses and adnexal masses should be documented. In particular, if you see a retroplacental fibroid that's measuring over 3 centimeters, those need to be mentioned. So those are just a few first trimester ultrasound updates. Okay, so now we're going to move on to the second trimester. And the second trimester scan evaluation is typically performed between 18 and 22 weeks. And the way I kind of like to envision it is it's divided into assessment of the fetus itself, as well as everything that's outside the fetus. So what's outside the fetus is the umbilical cord, the cervix, the placenta, the amniotic fluid, and then we're going to also be reviewing a lot of the structures inside the fetus. So these are all the components that we evaluate on a standard survey scan. And I'm going to be focusing today on these items that are in bold. So remember, we're talking about a level 1 second trimester ultrasound, okay, not a level 2. So first thing we're going to start out is we're going to start out outside the fetus. We're going to kind of zigzag a little bit, but right now we'll be outside the fetus and we're going to talk about fetal biometrics. And so basically I'm going to briefly review how these are accurately performed and how they are assessed. So the most important thing about fetal biometrics is to have reliable measurements. And in order to have reliable measurements, we must follow the rules. So the most important thing to remember here is that in a pre-viable fetus, which is, before 24 weeks, small errors in measurements are not actually clinically significant. But it's when errors at the extremes, such as IUGR and macrosomia, are going to become more, accurate measurements are going to come into play in the extremes, such as IUGR and macrosomia. So we must focus our attention on both the technical and analytical parameters and optimize the image and make sure that the correct imaging planes and endpoints are utilized. So first we'll talk about the biparietal diameter and the head circumference. So both of these are measured on an axial plane, and this plane should traverse the thalami and the cavum septum pellucidum. The transducer has to be perpendicular to the central axis of the head so that both the cerebral hemispheres and the calvaria appear symmetric and that the falx is midline. It's also important to know that the cerebellum or the orbits should not be seen on an accurate image. If you see these structures, then that means that the probe is too caudal or obliqued, and this could give an inaccurate size of the fetal head. So for the biparietal diameter, we're going to measure from the near field outer edge to the far field inner edge, and that's for an accurate measurement of BPD. The head circumference I'll talk about in a minute, but it's typically this particular parameter is utilized more if there's some kind of variation in head shape. And it's also important to remember that neither of these parameters are very accurate in the third trimester. They can be off by as many as 3 weeks. So let's take a look at this first image. If we notice, you have a nice midline falx. You can see the symmetric thalami. The calvarium appears nice and smooth, and the hemispheres are symmetric. So you can see how the measurements of the BPD are taken. So from the near field, it's the leading edge or the outer edge to the far field inner edge. So this is a good, accurate assessment of the biparietal diameter. And on this image over here, we can see that another important landmark here is the cavum septum pellucidum. In an ideal image, this should also be included when we're measuring our head circumference as well as our biparietal diameter. And I'm going to talk about that a little bit later on. So I'm going to show you now a suboptimal image. So on the left side here, we don't see the cavum at all. In fact, you can see a lot of shadowing here through the anterior portion of the fetal head. Granted, this is a third trimester fetus, but if you can just look at the difference, this is the same fetus. The transducer was just moved a little bit, but now you can see this beautiful midline falx. You can kind of make out the lateral ventricles, certainly can see the symmetric thalami and the symmetric cerebral hemispheres. Now let's look at our actual measurements here. Look at the head circumference here. It's 36 weeks and 6 days on this poor image, and 35 weeks and 4 days on this optimal image. So you can see how much of a difference a little bit of poor quality can make. So this head circumference changed by a week. So it's important that we look for this on our imaging and correct the sonographers if they're submitting images like this. Okay, so now we're going to move on to the abdominal circumference. And this is actually the most sensitive parameter for growth restriction. So if an abdominal circumference is less than 10 percentile, that can either mean that you have a small for gestational age fetus or a constitutionally small fetus. And you can report it as such, and then the obstetrician will correlate as to which one it's going to be. However, if the abdominal circumference is less than the 5th percentile and has a corresponding less than 10th percentile estimated fetal weight, then you can qualify this as a small for gestational age fetus. So how do we take these measurements? So these are taken in an axial plane at the level of these structures. So we have the portal sinus here. We have the umbilical vein. We should have the stomach. You should have a nice view of the spine, and you'll see in a minute why that's important. I'm sorry, the spine, and then also a nice view of the ribs. So this is an optimal image here for looking at the abdominal circumference. It's also important to know that you should not see the kidneys or the cord insertion on this image. If you see either of those two structures, then you are imaging too low. So the other important thing to remember is that the calipers here need to be outside the ribs. So here we have the ribs and we have the skin, and you actually have to be from skin to skin to get an accurate assessment of the entire abdominal wall. So again, measurements are taken skin edge to skin edge. We must look for the ribs. Errors in abdominal circumference can occur if we can't see the skin edge. For example, I'm going to go back to this image here. We can't really see the skin edge too well here. Sometimes, you know, the fetus positioning is not great, or you might have the placenta in the way. Sometimes the transducer can actually, if you put too much pressure, can actually compress the fetal abdomen a little bit. So those are important things to note and look for. And, you know, if that's the case, you know, you just get another, you know, wait for the fetus to move or get a different, different perspective. Oh, and the other thing that can contribute to an error in abdominal circumference is if there's not enough fluid. So some things to keep in mind as we look at our surveys and, you know, when we're noticing what all the parameters are, and if the abdominal circumference is off, it's important to look back, especially when it's off relative to the other biometric parameters, just to kind of go look back at your image and make sure that it was optimal, because it can mean, you know, a big deal if you're going to call a small for gestational age fetus. Okay, so let's say we have you know, an overestimation where our abdominal circumference shows a fetus that is too big. Well, this can be attributed to the following. It could be an oblique image. Perhaps we're seeing the cord insertion. Perhaps we're seeing the kidneys in our image. Well, that would be a suboptimal image. Perhaps the fetus is prone, and therefore the spine is resulting in shadowing, obscuring landmarks, disallowing us to see the ribs and the skin, and therefore not allowing us to make good measurements. Or maybe the fetus is measuring too small. Well, then we have to look at our image and make sure that all of the abdominal wall is included. For example, like we talked about before, we got to make sure that, you know, the sonographer has measured from the skin to skin, is not measuring from rib to rib. So remember to look for that. Also remember to look for that dependent fat or skin on the downside of the fetus, and make sure that this is included in our measurement. So here's another picture showing the abdominal circumference landmarks, just to review. So we have the fetal spine, the stomach, the umbilical vein, the portal sinus, the ribs, and of course, we want to make sure we can see the skin edge. So in the third trimester, it's not uncommon to struggle with dating. And the abdominal circumference is the most important in the third trimester. So if you just cannot find a good image, the sonographer cannot find for whatever reason, then a couple pearls to just remember is to make sure that the image shows a round abdominal circumference. And the other thing that you can look at is look at the actual diameter. So typically they'll do two diameters. In this particular example, there's 4.52 centimeters and 4.67 centimeters. As long as they're around 10 millimeters of each other, the image is pretty good. So this can give us a pretty good estimate, even if you may not be able to see your other landmarks. But again, this should be used mostly in the 3rd trimester when we're not getting a really good look at the fetus. Okay, so now we'll move on to femur length, our last biometric parameter.
And actually, Nisha, before the femur length, if I could just interject one thing.
Sure.
With abdominal circumference and measurements, is that the value, or is it the estimated fetal weight, or the combination that the sonographers are now getting in order for umbilical Dopplers?
Oh, in terms of like, well, actually, let me think about this. So if we have an estimated fetal weight percentile of less than 10, that'll automatically trigger a umbilical artery Doppler. Or if you have an abdominal circumference of less than, I think it's 5%. I don't remember what I put up there. Hold on. You know, I'll have to review that because I'm not sure. I think it's just the estimated fetal weight percentile of less than 10 that's triggering an umbilical artery. Yeah, but I think that's a good point. We might have to review that with them, actually.
Yeah, so I guess to refresh everybody on that, is that when that value, and I forget also if it's both or one of the two, but I think it's probably estimated fetal weight. If that's below a certain value, less than 10%, that's going to trigger an automatic order request from ultrasound to the ordering physician to get umbilical Dopplers. And that phone call from the sonographer will serve as a critical result report to the physician, and then they get the order and they'll do the umbilical Doppler. So it was one of these safety events that prompted that in discussion with Dr. Marche and the OB department, in letting, they really want to monitor these things closely, and they may want to do some pretty, especially in the older fetuses, they may want to induce a delivery earlier. So just as a little bit of a refresher as to what's happening interdepartmentally with regard to some of these values. So, all right, thanks for allowing me the interruption. I'll let you carry on.
Yeah, no, thanks for adding that in. Okay, so femur length is measured along the long axis of the bone. We're only measuring the ossified portion. That's the only portion that we're going to be able to see. We have to make sure that this lies parallel to the transducer in order to get the most accurate assessment. And also, we do not include the epiphysis in our measurements, only the diaphysis and metaphysis are measured. So this is a representative image showing how the femoral length is taken. Okay, so just to give you a big broad view reminder of what we've covered so far, we've covered the biometrics, and now we're going to move on to the fetus. So like I said, we're going to zigzag, so we're going to kind of cover these areas now. So why do we do a fetal survey? Well, there's many potential benefits, but the primary reason is to detect fetal abnormalities. In our case, the primary reason is to decide whether these patients are mothers are gonna go on to have a level 2 ultrasound. So there are many soft markers, and what soft markers are findings that are considered variants of normal, but they don't necessarily mean that there is an abnormality. But they are noteworthy because they do increase the risk for underlying fetal aneuploidy. Now, fetal soft markers are distinct from fetal malformations, but if you have a growth restriction and one or more soft markers, that will definitely increase your risk for fetal abnormality. So here's a list of the multiple fetal soft markers. And it's important to note that these can vary in their degree of association to aneuploidy. They must be interpreted in relation to other parameters, and in many cases, they must be interpreted in relation to each other. So one big disadvantage of these soft markers is that they can be transient. So that's why we perform our second trimester ultrasound between 18 and 22 weeks. So here's a list of the soft markers. Just remember, these are not diagnostic of a chromosomal abnormality, but they're very noteworthy. We're going to cover several of these. Echogenic bowel, ventriculomegaly, echogenic cardiac focus, choroid plexus cyst, single umbilical artery, enlarged cisterna magna, and renal pyeliectasis. And there are several other ones that are actually found in the level 2 scan. Those are the ones listed below here. Okay, so we'll start off with the fetal head and chest. So the fetal head, these are the parameters that we look at on the structural survey, and they include the cavum septum pellucidum, the lateral ventricles, the choroids, the midline falx, the cerebellum and cisterna magna, and the fetal upper lip. So starting with the cavum septum pellucidum, this is a very important structure. Absence of the cavum can indicate a fetal division abnormality such that it could demarcate the presence of agenesis of the corpus callosum, septic or septo-optic dysplasia, or holoprosencephaly. I'm going to spend quite a bit of time on this because I think this was probably the most important pearl I picked up from this talk. So bear with me. I'm hoping this will be the one pearl you guys take away if you don't take away anything else. And I think this is something that we weren't actually doing very well until I learned about this. So it's important to know the septum pellucidum can either be rectangular or triangular, but it is not a square structure. So here's an image here that actually, this was done actually at Silver. This is a triangular normal shaped cavum. And you can see the lateral ventricle, anterior horns here. And then I'm going to show you several other images. Okay, so here's a nice correlation between a diagram and a picture of the cavum. Okay, here's a picture that actually shows a rectangular shaped cavum. Again, this is normal. Notice the symmetry of the adjacent structures. We have the lateral ventricles, we have the thalami, we have the posterior horns, we have the choroid, we have the falx here in the middle. And actually anterior to the cavum right here, this black area or this hypoechoic area that isn't actually seen too well is the corpus callosum itself. Okay, here's a little bit of a magnified image. I just kind of wanted to show you, it's a little hard to see, the corpus callosum here anterior to the cavum. It's a U-shaped hypoechoic structure. Okay, so this is a midline sagittal illustration, and this shows the relationship of the corpus callosum, the cavum, and another structure in the brain called the fornix. So these red lines are demarcating the planes of section that can be obtained when we do fetal cavum assessment. And what they talked about in this conference is that many times what we image is actually the fornix, and we call that the cavum, when in fact, it's not the cavum. And that's really important, and I'm going to show you why that is. So it's important to know the fornix lies inferior to the cavum. So this is a cine clip actually from Silver Cross. This is one of the best cases I've seen of this. So we're going to start, the scan's going to start cranial, and we're going to move caudal so that you can kind of see how this goes. And just to kind of orient everybody, you can kind of start to see the frontal horns of the lateral ventricles. You can kind of see the choroid here. And here's, let's see, here's a nice triangular cavum. Again, remember, we're moving cranial to caudal, so we're still cranial here. And here's our cavum, nice and triangular shaped. And then pay attention as we move down. Moving down, we're going out of the cavum. Here's the lateral ventricles, and here we go. Here is the structure here. And you see this linear echogenic line kind of bisecting this. This is a fornix. There's two fornices. They're kind of parallel the cavum, just inferior to it. These are the fornices. And this is what sometimes you may notice the techs who are actually very educated on this now, we're submitting as a cavum. So pay attention to that. I'm going to show this clip one more time. That's the fornix. Look for that midline echo. Okay, we're going to start at the top again. This is the triangular cavum, the frontal horns, the corpus callosum. And then as we move inferior, here's the fornices with that midline echo. Okay, so you're probably wondering, why is she spending so much time on this? Let's look at these two images. Again, this is the cavum, triangular shaped. The image on the right is the fornix. Do you see this midline echo here? This is not the cavum. If we called this the cavum, we would be wrong. And so why is this important? Well, remember what an absent cavum indicates. It can indicate agenesis of the corpus callosum, holoprosencephaly, septo-optic dysplasia. This is a case where at 18 weeks, this was called the cavum. And I hope you all see why it is not the cavum. You see this midline echo? These are the fornices. So this baby went on to 34 weeks. And now we see colpocephaly with teardrop-shaped lateral ventricles. And this baby had agenesis of the corpus callosum. So this is a big medical legal issue, and that's why I think I really wanted to make sure that everybody understood this. The techs are very good at finding this now, but if you don't see it, call the patient back. Okay, so now we'll move on to the ventricular system. The most commonly detected abnormality of the CNS system actually will pertain to the ventricular system. So for proper measurement of the ventricular system, it must be performed in the axial plane at the level of the thalamus. Should be performed perpendicular to the long ventricular axis, and it should be performed posterior to the level of the choroids. If you have an offline measurement, that can potentially increase the size and result in overcalling ventriculomegaly. It's also important to distinguish the medial surface of the ventricle from the medial surface of the brain. So when the measurements are taken, they are performed inner edge to inner edge, just like the diagram here. And a normal ventricle is less than 10 millimeters. So ventriculomegaly, a couple signs of that would be the dangling choroid. Normally, the choroid should fill the entire ventricle. If you see greater than 3 millimeters of space between the ventricular wall and the choroid, then that is indicating that there's a ventricular dilatation. The only exception to this would be in the very early second trimester, where you may see a little bit of space. And in that case, and remember that's early second trimester, if you see that, you can just recommend a short-term follow-up in 1 to 2 weeks to reassess that. So ventriculomegaly can be associated with both chromosomal abnormalities as well as CNS pathology. Mild ventriculomegaly is defined as a ventricle that is larger than or equal to 10 millimeters and less than or equal to 15 millimeters. So what do we do when we get a case with that? Well, we recommend a level 2. The other thing that you can also look for is other soft markers that we talked about, you know, in the fetal head or fetal body, and make sure you do a detailed assessment. Some institutions might recommend a fetal MRI. I think for our purposes, we would just recommend a level 2. So this is a case of a normal where we have this nice, beautiful choroid filling the entire ventricle. Also, look at this nice image, which was taken almost at the level. You can kind of see the thalami here. It's not a great image, but you can see the cavum, septum, pellucidum, so we know we're at the right level. This is a case of mild ventriculomegaly. You can see this choroid dangling down. The measurement is 11 millimeters. So that's mild ventriculomegaly, and then as we progress even further, major ventriculomegaly, where the choroid is basically like bathed in the entire ventricle, and the diameter is 18 millimeters. Okay, so choroid plexus cysts, another thing that we see from time to time, and I never knew what to do with these, and I felt like the literature was all over the place. So this is what they said at the conference. These can occur in less than 1% of fetuses. On the one part, they can be associated with trisomy 18, but they can also be a transient normal finding. So if they're less than 3 millimeters, discrete and round and completely anechoic, and they are completely enveloped within the choroid of the lateral ventricle, then they can typically be followed. So if they're an isolated finding and they have all of those characteristics, they say that you can actually do nothing as long as the maternal serum screen is negative and as long as there's no evidence for advanced maternal age. We don't typically get the results of the prenatal testing. So what I've been doing is recommending that they be, that the presence of choroid plexus cysts be correlated with non-invasive prenatal testing. If we have choroid plexus cysts that are large, they're bilateral, there's numerous, we see other anomalies, or there's advanced maternal age, then recommend a level 2. So here's some examples of choroid plexus cysts. Remember, they can be unilateral or they can be bilateral, but you want them to be typically less than 3 millimeters, but they can be up to 10 millimeters. They may regress by 24 weeks. Here's an example of a unilateral choroid plexus cyst, and you can see that it's completely surrounded by choroid. Here's an example of bilateral cysts, again, completely surrounded by choroid. These were a little bit bigger, almost 7 millimeters. The cisterna magna is measured from the posterior inferior vermis to the inner cranium. The normal cisterna magna measures 10 millimeters. If it's enlarged, it can be associated with multiple anomalies, including a trisomy 18. If we see a mega or an enlarged cisterna magna, recommendations should be for a level 2 ultrasound and maternal fetal medicine consultation. And again, you can also look for other anomalies, but basically you want to recommend a level 2. So here's an example of a nice normal cisterna magna. We're measuring it from the midline vermis to the inner cranial wall, and it has to be less than 10 millimeters. And this is an abnormal or enlarged cisterna magna. I'm sorry that the measurement didn't come up, but it was greater than 10 millimeters. So this patient should be getting a level 2 ultrasound. Okay, now we're going to move on to the fetal chest. And I think it's probably been about 1.5 years that we've introduced the outflow tract views. But prior to that, we were doing just 4-chamber heart views. And prior to this conference, I had no idea how much information can be gained from this one single image. So there's 8 things that we can look for on this one image. So I wanted to review those with you. The first thing is the size of the heart. Normally, we should be able to fit 3 fetal hearts within the fetal thorax. That would be considered normal. So we want this fetal heart to be approximately 1/3 of the chest diameter. Another thing that we look for is a nice intact ventricular septum. We should be looking for the moderator band, which is an echogenic area that's going to reside within the right ventricle. We're also going to look for the aorta and the pulmonary vein and their entrance into the left atrium. It's also important to look for the offset of the tricuspid valve from the mitral valve. The tricuspid valve is a little more towards the apex of the heart than the mitral valve. The axis of the heart should be approximately 45 degrees. The rate and rhythm are important. Approximately 120 to 160 beats per minute is normal. And then lastly, look around the heart. there may be a little bit of fluid. Up to 2 millimeters is normal, but anything greater than that is considered a effusion. And then another little tidbit that I learned is to look for the proximity of the aorta to the fetal spine. This is normal. If you have too much space between these two structures, that could indicate a cardiac anomaly such as total anomalous pulmonary venous return. It's also important to kind of look that this is the only vessel in this region. If you see too much going on, that could mean something like an interrupted IBC or other types of fetal cardiac anomalies. And then also you want to look for the pulmonary veins, and you want to make sure there's 2 of them entering into the left atrium. If not, there's a higher risk for various congenital heart disease. So this is an example of looking at, here's the fetal spine, here's the aorta, and look at how much space there is between the aorta and the left atrium. This is a case of total anomalous pulmonary venous return. So I am going to now move on to the right ventricular outflow tract and basically just review what are we looking for here. So here's a diagram, and we're basically looking that the pulmonary artery itself is about the same size, but not larger, or maybe a little bit larger than the aorta. And we can see that the relationship here. You also want to make sure that the pulmonary trunk is located anterior and to the left of the aorta. If you don't see this, you can always recommend that the patient return in 1 or 2 weeks. However, if you don't see a normal RVOT or LVOT by the repeat scan, then it's time to recommend a level 2. So what do we assess on the left ventricular outflow tract view? Well, we want to make sure that the ventricular septum is continuous with the anterior wall of the aortic arch. And again, if we don't see this on the first scan, we can always bring the patient back in 1 or 2 weeks. But it's important to recognize that if you do not see a normal outflow tract view, or you can't get one, then something's up and you should recommend a level 2. Okay, what about echogenic intracardiac foci? We see these from time to time. What are they? Well, they are papillary muscle calcifications. They're typically unilateral. The majority of them, over 90%, are located in the left ventricle. They can be normal variants in 4 to 5% of cases, and the majority of them actually resolve spontaneously. But they can be also associated with trisomy 21 and 13, especially if there are multiple foci or if they're occurring in both ventricles. It is important to know that these are not associated with congenital heart disease. So what do we do with these? Well, if you're the radiologist, we report them. We also look for other soft markers that we've talked about earlier and will continue to talk about throughout this talk. What does the OB do? Well, the OB should correlate this presence with other risk factors for fetal aneuploidy, also correlate with the maternal age, and then consider whether non-invasive prenatal testing and fetal karyotyping need to be performed. If there is no maternal risk factors or no advanced maternal age, it's very typical for the OB to do nothing and just monitor. However, if these foci are right-sided in both ventricles, multiple foci, or prominent appearance, then the OB may consider doing a maternal fetal medicine consult and karyotype recommendation. So here's some examples of some echogenic intracardiac foci. It's important to know that these should be as bright as bone. If they're not as bright as bone, they could just be the normal papillary muscle. We also want to distinguish them from the moderator band. So in this case, here, these are bright, and you can just compare it to bone here. These are bright as bone. So this is a true echogenic intracardiac focus. This one's located in the left ventricle. How do I know that? I can kind of see the moderator band here representing the right ventricle. Here's another one here. Actually, there's 2 of them. They're as bright as bone. We know that they're located in the left ventricle because we can see the moderator band in the right ventricle. So now we're going to move on to the fetal abdomen. We'll focus a little bit on the stomach, the bowel, kidneys, and the cord insertion. Okay, so echogenic bowel. What is echogenic bowel? Well, it can be associated with multiple chromosomal abnormalities, including 13, 18, and 21. It can also be associated with non-chromosomal abnormalities, such as cystic fibrosis, infection, bleeding, such as after an amniocentesis, or if there was a placental abruption. It could be associated with other malformations, as well as IUGR, or even placental failure. Bleeding is actually the most common cause of echogenic bowel. And it's also important to know that fetal, in order to call it echogenic bowel, it should be more echogenic than bone. So here's some examples of echogenic bowel, a sagittal or longitudinal image of the fetus. You can see this bowel is brighter than the adjacent spine. This is a transverse image. You could see this bowel is brighter than the adjacent pelvis here. So another soft marker that we should be aware of, if we see this, we should associate and look for other soft markers, but this baby would definitely need a level 2 ultrasound. Another tidbit just to kind of know, when do we see bowel? Well, you're not going to see bowel typically in the first trimester early on. At about 13 weeks, you might start seeing some fluid-filled small bowel loops. By 24 weeks, the colonic loops can be seen. And typically in the late second or third trimester is when we start to see more and more bowel. And what constitutes normal bowel? Well, normal, this should actually say normal bowel, it should say normal small bowel, but normal bowel is less than 7 millimeters in diameter and less than 15 millimeters in length. So here's an example of an abnormality that was detected at 24 weeks. This bowel is dilated. It's greater than 7 millimeters. We can also see that there's an elongated, this was definitely longer than 15 millimeters. This was suspected as abnormal dilatation. They did a follow-up in the third trimester. You can see it's now looking worse. It's more dilated. There's a longer loop involved. And by 36 weeks, this is what the bowel looks like. So just remember 7 millimeters as kind of your, what do you call it, threshold for where bowel should be considered abnormal. And again, just remember, if you see it looking more than 7 millimeters or greater than 15 millimeters in length of dilatation, recommend a level 2. So we'll move on to the fetal kidneys. These are typically, we do these on, we do axial images. But in order to qualify as a substantial image for a fetal kidney, we have to make sure that we either identify the renal pelvis or Gerota's fascia, which is the echogenic covering around the kidney. So here we see two nice renal kidneys. You can see the Gerota's fascia. In this image down here, you can see the renal pelvises. So these are definitely two kidneys, because if we don't see one of these structures, you cannot be confident that you have seen a fetal kidney. And that's important because we're going to talk about that in a minute. If you can't see one or both kidneys, well, then you can ask the sonographer to do one of two things. You can ask them to turn on the color, and then you look for renal arteries. So here's an image here where one kidney was seen. You can see the renal pelvis. Not really sure what's going on here. Not sure if this is a kidney or if it isn't. But when we turn on the color, you can see two renal arteries and feel more confident that there is the presence of two kidneys here. Another thing that you could do is ask the sonographer to do a coronal image. Here's a diagram showing the fetal kidneys in a coronal plane, and you can see the pelvises here. Again, here's an ultrasound image showing a nice coronal plane of the kidneys. Again, we feel confident that these are the renal kidneys because we can see the renal pelvises. We could also ask the sonographer to turn on color on a color image, for instance, if we don't feel confident about the presence of two kidneys. So just remember, we always want to look for Gerotis fascia or the renal pelvis to make sure that we see the kidney, and color is your friend. You can have them turn it on or do a coronal view to make sure that we have two fetal kidneys. Another thing that I wanted to also discuss is the renal pelvis. This is measured in the anteroposterior diameter on an axial image. And the renal pelvis can actually vary in size based on the gestational age. Very early in the intrauterine pregnancy, between 11 and 14 weeks, up to 1.5 millimeters is normal. In the second trimester, typically when we do our structural surveys, up to 4 millimeters is normal. In the third trimester, however, up to 7 millimeters is normal. Anything over 10 millimeters is hydronephrosis. So we'll keep that in mind as we look at the next few cases. So what do we do when we have an abnormality? Let's say we have a unilateral abnormality of pelviectasis. Well, you can recommend a follow-up at 32 to 34 weeks. And on the 32 to 34 week follow-up ultrasound, if there is persistent pelviectasis, and remember, this would now be defined as greater than or equal to 7 millimeters, we're going to recommend that a postnatal renal ultrasound be performed. What if we have bilateral pelviectasis? What do we do then? Well, then we should look at the amniotic fluid index. If the amniotic fluid index is abnormal, we should recommend a level 2 ultrasound. If the amniotic fluid index is normal, then as long as the renal pelvis diameter is less than 10 millimeters, it's perfectly fine to recommend an ultrasound at 32 to 34 weeks. If it's greater than 10 millimeters, remember that's considered hydronephrosis. We're probably going to recommend either a level 2 or a maternal fetal medicine consult. And typically what they'll do is ask for ultrasound every 2 to 3 weeks to follow the fetal kidneys. Okay, so we have now we've moved out of the fetus, and we're going to go back outside the fetus. And we're going to look at the supporting structures, including the umbilical cord. We'll take a look at the cervix, the placenta, and the amniotic fluid. So there are times where we see a single umbilical artery or a 2-vessel cord. The umbilical cord is actually, it can be imaged in 2 ways. Part of our surveys, we either see the cord itself when we look as a cross-section of the cord, and we also look at the cord as it's inserting onto the fetal abdomen at the level of the bladder. Abnormalities of the umbilical cord can be associated with renal and cardiac anomalies, as well as IUGR. So if we're doing a structural survey and we see a 2-vessel cord, we should recommend a level 2 and a fetal echocardiogram because of these associated abnormalities. Here's an example of, or 2 examples of 2-vessel cord. So here's one at the level of the fetal bladder. You can see there's only 1 cord instead of the 2 cords surrounding the bladder. And here's a cross-section image where you see only 1 artery and vein. And then this is just a nice color image showing 1 artery and 1 vein. Let's talk a little bit about nuchal cords. What do we do with nuchal cords? Well, if it's a single wrap, there's actually nothing to be done. You can just comment on it in your report. However, if you see multiple wraps, that's actually that's an emergency. I think the patient should be kept, and you should call the obstetrician and ask them what they would like to do, and they may consider doing additional imaging or testing. So now we're going to move on to the cervix. The cervix is normally at least 30 millimeters in length. Cervical incompetence is actually variably defined. However, a cervical length of less than 25 millimeters at or below 24 weeks is often used as a cutoff. So how do we decide when we do a trans-abdominal scan versus a transvaginal scan for assessing the cervix? Well, the main thing to remember is whether there is or isn't a risk of preterm delivery. So if there is no risk for preterm delivery, a transabdominal scan and assessment of the cervix can be performed. As long as the cervix is measuring 30 millimeters or more, you're done. If, however, on transabdominal scan, you get a measurement of the cervix of less than 30 millimeters, you have to proceed on to do a transvaginal ultrasound. Now let's talk about the other category of patients who do have a risk of preterm delivery. Those patients, transvaginal scan is required. So I'm just gonna kind of briefly go over the cervical transvaginal assessment. Just a couple highlights. First of all, we have to make sure that the bladder is empty. Otherwise, you can have inaccurate measurements. We always obtain 3 images, and we always use the least measurement of this white stripe, which represents the cervical length. There is actually a website, 123radiology.com, where you can watch a YouTube video on how this is actually looked at and assessed. And I think it's kind of important because it goes over some of the abnormalities like funneling here. So you guys might want to look at that at some point. But if the other important thing is we don't look at the cervix just on grayscale imaging, we should also look at it, at least get one color image of the cervix to make sure that there's no vasa previa. So we're going to move on to the placenta. The placenta has a lot of items that need to be looked at. First and foremost, I just kind of want to let you guys know that placental grading is no longer, we're not doing that anymore. Institutions are not doing that anymore just because they haven't found any correlation between grading and fetal outcome. So that's been removed. But when we look at the placenta, there's many things that we look at. We look at the morphology. We want to make sure that it's a discoid type of morphology. It has nice rounded margins. The thickness of the placenta is normally between 2 to 4 centimeters. It should not be too thin or too thick. We should look at the echogenicity and make sure it's nice and homogeneous. Sometimes you might see some venous lakes, you may see calcifications. We want to look at the location of the placenta, make sure that there isn't any evidence of low-lying placenta or placenta previa. We look at the cord insertion. We're going to look in 2 planes, longitudinal and transverse, to make sure that the cord is inserting nice and centrally and that there's no evidence of a marginal or velamentous cord. We're going to look for abnormalities of placental adherence. We're going to look for the accretas, the impeditas, or precretas. We're going to make sure that there's no retroplacental mass. Make sure that there's a nice hypoechoic zone in the retroplacental region. We're going to look for any hematomas or any other masses within the placenta that would indicate an abruption or any kind of tumor. So here's an example of a couple morphologic variations that we may commonly see when we do these surveys. The first one here is called the succintrate lobe, and this is a longitudinal color image of the placenta. It's, I think, at 24 weeks of gestation, and you can see that there's 2 separate placental lobes. There's the main lobe here and then the succintrate lobe down here. And if we look at the actual cord insertion, you can see that this is actually inserting at the margin of the main lobe, near the membranes that are connecting the 2 lobes. So as these blood vessels travel from the main lobe and they cross posteriorly towards the succintrate lobe. Why is this important? Well, this would be a risk for vasa previa and retained products of conception. Here's another image of a circumvallate placenta. This is a longitudinal image. It was done at 21 weeks of gestation, and you can see this raised edge of the placenta. Why is this important? Well, this would be at a risk for preterm delivery, small for gestational age fetus, or chronic abruption. The placental location is also important. Normally, it can be inserting either anteriorly, posteriorly along the fundal right or left margins. There's two categories of abnormalities in placental location. They're either titled low-lying placenta or placenta previa. This is the current terminology. They're now no longer using the terms partial, marginal, or complete previa. Those are no longer considered acceptable. So in a low-lying placenta, you're going to have a placental margin that is near or within 2 centimeters of the internal cervical os. And in the placenta previa, you're going to have complete coverage of the internal cervical os. So what do we do with placenta previas? Well, when we see them in a structural survey in second trimester, we follow them up at third trimester. But then what happens in the third trimester? Well, it could resolve. But it's important that we make sure that we do a color image because we want to exclude the vasoprevia, which is what we're seeing here. So we see this is a transvaginal scan, and you see these bright vessels that are coming right across the internal cervical os. Here's another example of vasoprevia. Again, transvaginal scan, you see these prominent vessels right near the internal cervical os. When you put the color, or I'm sorry, a Doppler waveform on there, you can see the actual umbilical arterial waveform pattern. And this is probably the most important piece of this vasoprevia assessment. This is an example, and this was actually, yes, this case was actually from Silver Cross. So this is an example of a patient that had, she has both a placenta previa and a vasoprevia. So we see two important things. One is we notice how important it is to turn on color, because on this grayscale image, you'd have no idea that there's a vasoprevia, but once we turn on the color, we can see that there's fetal vessels right here near the internal cervical os. And actually, we can see that these are associated with the placenta previa. So these two go hand in hand, placenta previa and vasoprevia. So it's important to keep these in mind and important to turn on color imaging when we're following these patients. So let's talk a little bit about placental cord insertion. There are several different types, central being normal, eccentric being not central, but just about greater than 2 centimeters from the placental edge. A marginal cord insertion is considered when it's inserting within 2 centimeters of the edge, and these need to be followed up because these cord insertions can become velamentous. And what is a velamentous cord insertion? It's when the cord actually inserts on the adjacent membranes. It does not insert onto the placenta, but the adjacent peripheral membranes. And that's important because for this obstetrician, because those patients are not delivered transvaginally, instead will go on to have a C-section. So remember, we always want to turn on our color because we want to make sure that there's no vasoprevia. And we always want to make sure that the cord insertion is looked at in transverse and longitudinal planes, which is what we're doing for our surveys and anytime we're assessing the cord insertion. So here's an example of a marginal cord insertion. This is a longitudinal image. It was done at 20 weeks gestation. And you see that the placental cord insertion is near the margin of the placenta. Here's the placental margin right here. It's within 2 centimeters of the edge. So this is a marginal cord insertion. This patient needs to have a follow-up to make sure that this doesn't progress onto a velamentous cord insertion later in pregnancy. So here's an example of a velamentous cord insertion. This is a longitudinal image. Instead of the umbilical cord inserting onto the main placental mass, we can actually see that there's subtle insertion onto the amnion-chorion membranes. And again, we want to make sure that we turn on the color to make sure that there's no vasoprevia. Just briefly want to talk about fluid in the fetus. So we've been measuring, two ways to measure the fluid in the fetus are the amniotic fluid index, also the deep vertical pocket. We're actually going to start doing both of these. And the reason for that is the deep vertical pocket has a higher sensitivity. The amniotic fluid index can actually overestimate oligohydramnios. So I spoke with OB and we decided that we're going to be utilizing both measurements. So the deep vertical pocket measurement normally is between 2 and 8 centimeters, and amniotic fluid index can vary based on the gestational age, but can range normally from 5 to 24 centimeters. And then a final word in regards to BMI. You guys might have noticed that that's also being reported by the or calculated by the sonographers. And the reason why this is important is that patients with large BMIs they can have increased risk for multiple reasons. One is we may get a poor visualization of the fetal structures, including the fetal kidneys, the fetal heart, and numerous other structures. And also those mothers have an increased risk of diabetes, which could result in macrosomia as well as other disorders, as well as maternal hypertension, which can result in placental issues, etc. So some institutions are actually performing level 2s on anyone over a BMI of 30. We're not doing that yet. What I've been doing is if I have a patient with a large BMI where I can't see multiple fetal structures, I'm actually repeating the scan in 1 to 2 weeks. And if it's still limited at that time, I'm recommending a level 2. So this is the end of our whirlwind tour. I hope that you've learned a few take-home points. Remember, pay attention to the biometrics. Measurements of the fetus, particularly the abdominal circumference, are important. If you can't see a fetal structure well, please get a short-term follow-up in 1 to 2 weeks. If you still can't see it, recommend a level 2. And lastly, remember the structures inside as well as outside the fetus. Don't forget the umbilical cord, the fluid, the cervix, and the placenta. And don't be afraid to do a transvaginal scan. And please remember to turn on color Doppler to look at cysts and for vasoprevia. Thank you.